Okay, so welcome. My name's Catherine, and I'm a client partner with Fraser Health Wellbeing team. Welcome to the first in our Wellbeing guest speaker series with Dr. Geraldine Pryor. Dr. Pryor is a 45-plus year University of British Columbia endocrinology clinician, scientist, and teacher. An award-winning clinician scientist, she's known for her innovative concepts that value estrogen-progesterone balance and have the potential to transform and improve understanding and treatment of women's reproductive-related issues. She founded the UBC Center for Menstrual Cycle and Ovulation Research, CEMCOR, in 2002 and launched its informative website in 2003. Dr. Pryor is an internationally recognized thought leader on menstrual cycles, ovulation, perimenopause, menopause, and osteoporosis prevention with over 300 highly cited publications. Dr. Pryor grew up in an Alaska fishing village, got an honors MD from Boston University in 1969, became a Canadian in 1983 due to her belief in the universal healthcare. So without further ado, I'll hand it over to Dr. Pryor.
Thank you, Catherine. I'm very happy to be here and to share with you some experiences and ideas and knowledge about perimenopause. My expertise in perimenopause really began when I experienced it myself. And at that time, there was no accurate information about it. So my focus is on women's experience and why we experience what we do. I apologize ahead of time that I may need to sit down because I'm having some degeneration in my lower back and it's hard for me to stand for a long time. And I hope you'll be able to see me even if I sit down. So we're talking about perimenopause. It's long, it's confusing, it's misunderstood primarily because it's considered part of the same process as menopause, and it couldn't be more different. To borrow a British phrase, it's as different as chalk from cheese. So before we start, I have no commercial conflicts of interest. I'm deeply grateful to live on the unceded territories of the Coast Salish people, and I think progesterone is pretty lovely. So today we're going to talk first about the historical context of perimenopause and menopause. Where we got these ideas that keep coming up and don't seem to go away even though they don't fit. We'll talk about the reality, the measured hormonal changes that are not in the general literature in general. We'll talk about what women in the general population experience in perimenopause from an excellent study in Australia, about Health Canada evidence-based therapies, and then about a woman-centered way that I would approach treatment of perimenopause. Okay, so what I'm trying to show you is a very old Gary oak with an extremely convoluted limb, which is sort of symbolic of venerable old age. And behind it are the spring azaleas that are in bloom. So she's calling MedIT. Okay, for the moment, but I'm still not up there, but at any rate. Okay. Then I dreamed I was pregnant. Now you say, what the heck does that have to do with perimenopause? But this is an incredible experience that I had myself. The words that I put there are the words from Janine O'Leary Cobb, who wrote one of the first books about menopause, published in 1988. And what's fascinating to me is that a Kong woman of the Kalahari, a hunter-gatherer person, said, not long ago, I had a dream that I was pregnant. So an urban sociology professor, me, and this hunter-gatherer woman had the same experience. So that has to be telling us something about what the hormones are doing, because hormones are not low during pregnancy, exactly the opposite. So here's a typical, very pregnant Kung woman carrying her youngest, about a 5-year-old, nursing on demand, walking 16 kilometers a day, gathering the food that her family needs. So that sort of physiological women's experience clue about what's going on in perimenopause is so different from the notion that we all get. But in my search for evidence, I found there was a British physician named Edmund J. Tilt, who was working, of all things, in France in the 1870s, who wrote a book called The Change of Life in Health and Disease, a practical treatise on the nervous and other afflictions incidental to women at the decline of life. How's that? But this fellow Tilt was a good physician. He was a bright man, and he gave us the very first record we have of perimenopausal women. He had about 500 women that he was seeing, and he kept track of what they were experiencing. So he talked about the flushes as a safety valve of the system at the change of life. Remember, this was the era of humors. And the Latin name is, I love it, Ardor Galacticus. It sounds like something out of Star Wars, right? Relief awarded by hemorrhages. Again, the idea, but mentioning heavy flow in connection with perimenopause is something almost never that a gynecologist will do. And yet a third of us experience that. Breasts swollen, painful. And that was my big symptom, was that I just had such sore breasts. And turbulent activity of the reproductive organs. So this man, 150 years ago, was getting at what was really going on. In fact, he gave us percentages. 53% had hot flushes, 30% had hemorrhages, 3% had breast tenderness. But what do the people in our recent history, the experts, say? Menopause is a serious medical condition endangering the health and happiness of women. And that was the famous Robert Wilson, who vowed that he wasn't related to drug companies at all, but turned out he was. In the 60s, he's the one who said every woman needs estrogen replacement, quote, quote, therapy. And here's a more recent one. We suggest treatment with estrogen for all women with any stigmata of hormonal deprivation. How bad does that sound? I mean, those are loaded words. Stigmata is a religious symbol of the cross, for goodness sakes. So this is the kind of perspective that we're living with. An accurate one from 150 years ago, not so accurate from 20, 30, and more recently. So the problem now is that we equate perimenopause with menopause. You know, it's like the media says, keep it simple. You know, they're the same. Just yeah. And what's more, they're all about dropping estrogen levels. Estrogen deficiency is a term you hear, right? But the opposite is true. Now, add to that we have different names. Climacteric, change of life, menopause, perimenopause, menopausal transition, postmenopause, decline of life. I mean, and unfortunately, this word menopause is used in three dramatically different ways. But I think of perimenopause as the ovaries grand finale. You know, at the start of a fireworks show, it's the orderly Roman candle, and then this one, and ooh, ah. And at the end, it's boom, 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 boom. And that's exactly what's happening in perimenopause. Our ovaries are getting rid of all of those follicles, so we don't have estrogen-making things to give us a period when we're in a nursing home. So what are the evidence-based hormonal changes in perimenopause? So let's start off with kind of a simple diagram. These oval things are our two ovaries, and one of them is probably making a large dominant follicle, and there evidences of previous follicles that have ruptured and released an egg. The cells, the granulosa cells from each follicle that also makes estrogen, makes a funny little hormone called inhibin, which keeps FSH, follicle stimulating hormone in the pituitary, in check. So the estrogen that's made by the dominant follicle and the inhibin both keep FSH low. So inhibin, so it's a feedback loop that works extremely well during the premenopausal years. One of the ways we can tell things are starting to go sideways in perimenopause is there's an increase in non-identical twins. So what's happening in perimenopause, now you notice there are fewer follicles remaining in the ovary, but now more are getting stimulated, more like dominant follicles. They're making more estrogen, and inhibin, I don't know, because the follicles that are remaining there are older. They were formed before we were born. Any rate, inhibin levels are low, so FSH starts to rise and more follicles are recruited. Therefore, more estrogen is made each cycle. And the feedback that normally would keep the cycle and hormones in check is broken. And this is on purpose, to get rid of all of those follicles. It makes a heck of a lot of sense. Okay, so let's first talk about how we might name accurately. So this whole thing is called perimenopause, but gynecology focuses on the menopausal transition, by which we mean starting with irregular cycles until you get a skipped cycle, then you're into the late menopause transition. And there are still many people who say the beginning of menopause or post-menopause is the final menstrual period. But how do you know it was final? You don't until a year has passed. And even that is a statistical thing. If you have menopause at a normal age, 45 and older, then you still have a 10% chance of getting another normal period. If you have a younger age at menopause, you have a 20% chance. And I'm going to do a little aside here because I think it's important. If you felt different, PMS, bloating, sore breasts, something before that period, it is not endometrial cancer. You don't need an endometrial biopsy. It is an extra period, okay? But it's extremely, if there's any question in your mind, because cancer is awful, you should have that biopsy. But if you have no question in your mind, it's normal. Now, we're going to spend some time in a minute talking about this, and it can be very long. For me, it was at least 5 years of regular cycles, but the hormonal changes and the experiences of perimenopause. And currently today, we go to see our family doctor, we describe what we're experiencing, they ask about our periods, we tell them they're regular, and they say, oh, you must be depressed. or you need sleeping pills, or you're too young, or you're not in perimenopause, and that's not correct. So what ages? On average, very early perimenopause could start as young as, normally, as young as 35. And the average age from several studies in the US for the onset of a skipped period is 48 years, and the average age at menopause is about 52. But there's wide swings on both sides of those. Okay, so now let's talk about what we know about the hormonal changes. This was the first study by Nanette Santoro, who's head of OBGYN in Colorado, to actually say estrogen levels are higher in perimenopause. So let me talk you through this. So this is measurement of a urine. Urine from the solid dots here are women younger than 30 years of age across basically one cycle. And the open circles here are from women older than 37, often who had night sweats or other things going on. So you can see that there's really higher estrogen levels in these perimenopausal women who, because their cycle's still regular, were in very early perimenopause. So there was another study that was done, a large population-based study in Australia. Now, I had visited Australia, so I knew these researchers were doing this study, and I was looking for their results. So I picked up my journal, Clinical Endocrinology and Metabolism, when it came in 1995, and I started flipping through this article, and I saw a diagram. And I'm going to show it to you in a minute, but I saw it and I said, yes, because it showed high estrogen levels. So here's the background to the study. It was a random population-based study, and they used the census or voting records to invite people to join. Women were 45 to 55. They'd not had a hysterectomy. They weren't taking hormones or birth control pills. They'd had flow within 3 months, so they were still in perimenopause. And they ended up with 438 women with a reasonable participation rate of 56%. In other words, that means everybody they asked, 56 agreed to be in the study. Their average age was 49. Their body mass index was just a touch above the optimum. And they'd had their pap tests, and there were very few smokers compared to the population at large. So they were a healthy cohort. So they were just starting a prospective study, and the design of the study said, we're going to measure a serum hormone early in the follicular phase each year when you're in this study. And that's what I'm going to show you now. So here are the results, and what we're paying attention to are the dots here. And I'll explain to you what the different ones mean in a sec. So this is estradiol levels going up here. Each dot is an individual woman, and this line across here shows the average from premenopausal women in the same, another Melbourne study. It was the normal range. So we would expect all of these dots to cluster around here, but you can see some go way up, extremely high. So the first category here, and they didn't really know how to classify perimenopause things in those days, was women who had regular cycles, but remember they're 45 or older. These women had changes in flow, and it could be lighter or heavier flow. These women said they had changes in their cycle length. It could be either shorter or longer. These women had changes in both flow and cycle length, so it's the biggest group. And these women had been 3 or more, almost up to 12 months without a period. So they were in that late perimenopause phase. So I think you can see there's a huge scatter of data. This line is as high as estrogen should ever be in a premenopausal cycle. So you see why I was excited, because there's so many high ones. And then I read the summary. And the summary said, estrogen levels drop in perimenopause. And the reason they said that, well, I was really mad. In fact, I called them and I got the poor statistician, and she said, I just did the test that he asked me to do, which was a geometric mean comparing this group with this group. And yeah, this group has higher levels than this group. But ignoring all of these high levels, I mean, look at how many are higher than the mid-cycle peak. We're talking into the 2000s here for estrogen levels. In fact, it makes my breasts sort of look at it. Well, I went ahead and looked for studies in the literature that had measured premenopausal and perimenopausal women in the same lab, because different assays differ in different places. And what I found were these data here. So the solid bars are the premenopausal and the open are the perimenopausal women. Here's early in the cycle, starting in flow and for about 6 days after. And here's late in the cycle, and we didn't know if they were ovulatory or not. But in both cases, estrogen levels on average were statistically higher than in premenopausal women. This is not estrogen deficiency. This is not dropping estrogen levels. So if we do a cartoon of estrogen across the life cycle, it rises pretty rapidly in teens, and often there's an overshoot. And this is sort of the average of the cycles during the menstrual cycles. And then it goes to haywire in perimenopause. And if this were accurate, the levels would be up to the ceiling here rather than as they are. Okay, so we know estrogen increases in perimenopause. What about progesterone? Well, this is going back to Nanette's study before. So the dark are the younger women, and the open circles are the perimenopausal women. And I think you can easily see that progesterone levels are lower. Cycles were regular, estrogen was high, and progesterone's lower. Well, I can show you, and I like these data because it's using things we can measure. So a woman was in a study, I was also in the study, in which we were looking at women with regular cycles who were normally ovulatory at the beginning, and we simply asked them to keep their basal temperature and record of cycles for a whole year. So here she is. The turquoise is cycle length, and I think you can see that cycles were pretty regular across the year. Here's the luteal phase, and the line there is 10 days, which is the lower limit of normal for the luteal length. So she's normally ovulatory except for one short luteal phase in cycle 13 here. Well, you know, we finished the 1-year study and we went on with our lives. And then I got a letter. In those days, we got letters. We didn't get emails. Then the letter said, you know, I'm good in my life. I have a new partner, you know, things are fine, but I'm having heavy flow. And she said this, when I try to cuddle, I have a puddle. I never forgot that. At any rate, and in talking to her, I'm trying to figure out what's going on. And I said, how are your cycles? Oh, they're still regular. And it turned out she'd been keeping her records since she'd been in the study. So this is her 10 years later. So I think you can see that her cycles are still regular. Statistically, they're shorter than they were 10 years before, and that's normal. But look what's happening with ovulation. She's ovulated in all except cycle 13 and also cycle 2 here. but every single one of her ovulatory cycles has too short a luteal phase. So it's showing us that progesterone is lower, even though estrogen is maintained. If you think about a sort of cartoon of the life cycle of progesterone, it's different than for estrogen. It takes a long time to ramp up to the normal levels in young adulthood, and it decreases more quickly in perimenopause. So estrogen's higher, progesterone is lower. There's another important hormonal system that's disturbed in perimenopause, and this is the stress hormone system. If you think about it, it makes a lot of sense because the things we were used to in periods, in feeling young, in knowing we could get pregnant if we didn't take precautions, those things have changed or are changing. So there's a social stress part of perimenopause that's very real, especially if we value ourselves for young, sexy looks, because we don't always keep that. And one of the things that's high, especially during hot flushes, is norepinephrine, which is a central brain catecholamine. It's part of the fight or flight kind of response system in the body. So what happens is that every time, well, I showed you the big array of levels, but in an individual woman over 20 minutes or something, estrogen levels are dropping. And every time estrogen goes down, there's an increase in both the cortisol and ACTH and those adrenal stress, but also norepinephrine increases. And we now know that it's those downward dropping levels of estrogen that trigger hot flushes, that trigger bone loss, and the anxiety and depression that may increase in perimenopause. It's not the actual level, it's the change. That's an emergency. The brain is telling us it's an emergency. So with these hormonal changes that we've talked about, very dramatic changes in hormone levels, what changes do we experience? Do women experience? Well, there's tons of them. Can't sleep, tired to death, anxious, gaining weight, can't seem to cope, pissed off, heavy flow, breast tenderness. Infertility is a big one, especially for women who have had some fertility-related issue in the past. It really does bring up those kinds of issues. Now, before we get into all the myriad of symptoms, however, remember that most women pretty much sail through it. They say, oh yeah, I notice my periods are getting funny. I can't predict them anymore. Or I'm waking in the night when I never did before, or something. But it's only 15, maybe 30% of us that have a symptomatic time. But those of us who are symptomatic need support. We need help in the workplace so we can continue to be productive or lose as little time as possible. So we're coming back again to that same Melbourne group of women I talked about before. And these women, again, we went through most of this before. 80% were partnered. Parity, interestingly, was three live births. But 47% of these women, now admittedly, they were specifically asked specific questions, experienced 5 or more symptoms. And some of them were quite problematic. So I'm showing you in this graph the things that were experienced by more than 30% at some stage of perimenopause. So this is very early transition when cycles are just irregular, late transition when you've skipped a cycle, and then late perimenopause when in that last year without a period. So fatigue is common across all of those. Depression gets in fact, most things get worse in that late transition from the first skip period till your last period. Sleep trouble is common across and worse here. But notice how many of these things are already here in very early perimenopause in women who have no change at all in their periods. And that is super important to remember. Now, it happened, this paper was published some years later, and I asked them, are you asking about breast tenderness? Because most of the questionnaires about perimenopause are menopause questionnaires. And you don't get breast tenderness in menopause unless you're taking estrogen, of course. And I also suggested they ask about heavy flow, which they didn't, but they did ask about breast tenderness, and it's highest in these early years in perimenopause and then gets better. Just to show you what's happening, this is an actual woman. Here's a breast when she was premenopausal. Here's one about 5 years later. She's gained a little bit of weight. It was the same machine, the same distance, the same exposure. In other words, tried to keep all the technical things the same. And I think you can see how much bigger those breasts are. So this is an evidence of the higher estrogen, lower progesterone in perimenopause. Okay, so let's talk for a bit about very early perimenopause, because I think this is the most important thing for us to know, to share with our friends, and for healthcare providers to know, is that this can be the most symptomatic time for a woman. And if she is not acknowledged for what she's experiencing, she's going to lose faith in the healthcare system. She's going to lose faith in herself. Am I imagining this? Is this all in my head? You know, it's not good. So I asked myself the question, can we figure out a way that a woman could tell for herself, or that a doctor could tell, if a woman with regular cycles was in very early perimenopause? And I came up with this. If a woman with regular cycles has any 3 of these 9 things: new onset of heavy flow, shorter cycles, usually less than 25 days, but if somebody usually had a 33-day cycle and it was down to 27, that would be definitely shortened. New swollen or lumpy breasts, sore, swollen, lumpy breast, mid-sleep wakening. So even though anxiety and depression increase in perimenopause, the typical sleep problem is fall asleep like nothing and then wake a few hours later, wide awake and wired. It's just weird. It's so strange and so peculiarly perimenopausal. Increased cramps. Now that's a funny story, because there's a daily menstrual cycle diary that I'd used in premenopausal women to record experiences and things. I'd been doing it myself. And when I first made the perimenopause diary, I took cramps off. And I had to put it back again because they get worse for some women in perimenopause. Here's a typical one: the onset of night sweats. Waking up during sleep, feeling too hot. Now, my first night sweat was so dramatic. It was sometime in the wee hours of the morning in November, I remember, and it was dark and cold. And I was just awake and I was furious. I was madder than hell. I could not believe, where did this come from? And there was no dream in my head. And I was ready to blame my dog or my partner for snoring or something. Everything was quiet. I got up and went to the washroom. By the time I came back to bed, I was dripping. And I said, oh, that's a night sweat. Okay. New, markedly increased migraine headaches. So some women will say, I had migraines when I was a teenager or when I first started the pill, and I haven't had them for years. They start getting them again in perimenopause. Thankfully, it's not that many, but they can be very difficult to treat. New, increased premenstrual mood swings. And in fact, most people in PMS clinics today are 35 and older. I mean, it's the rare one that's in her 20s. So, yeah. And this one is true, although most of us, kid ourselves that we aren't eating more or doing less exercise. Weight gain without changes in exercise or appetite or eating. Mm-hmm.
Do you have that list as a resource?
Mm-hmm. The SEMCOR website has the source for it. It's called How Can I Tell I'm in Perimenopause? Good question. And it's published in BC Medical Journal. So we've talked about hormone changes. We've talked about symptoms. What do we have that Health Canada says you can use to treat perimenopausal symptoms? Anybody? There is nothing. So if we're talking about every woman goes through this phase, 15 to 30% are highly symptomatic. What is it about this? Okay. All right. So now you get my take on how to approach perimenopause. And I'm very happy to tell you that we finally have some solid scientific evidence about a beneficial therapy that also isn't harmful. Now, before we get into that, the current universal guidelines, SOGC, North American Menopause Society, International Menopause Society, Mayo Clinic website, you name it, they all say, if you're 60 years of age or under, you can take menopausal hormone therapy. Now, perimenopausal women are by definition 60 years of age or younger. That guideline does not take into account that perimenopause and menopause are different. And that's been pushed and pushed and pushed right now. So I'm going to show you a different approach. But let's start with something very simple and general. And, if I only did this, I would get very unhappy patients. But I'm very serious about this. You are not old. You're going to live through this. Nobody died from perimenopause. Okay? Second thing, avoid estrogen therapy. If your own hormones are high already, and you take estrogen on top of that, and the feedback system is broken, you could get sky-high levels that could be bad for you. So avoid it until you've been a year without a period. And this is the hardest one. It certainly was hard for me. Take care of yourself. Typically, maybe some younger people's generation is less so than mine, but we were taught that women's job was to take care of other people. And perimenopause is saying it's time to take care of yourself. Stop making your 12-year-olds lunch. They can do it. Then they won't gripe about it, what you put in it, etc. In other words, don't volunteer. Ask for what you need. Take time out to do the things that make you happy, that make you feel relaxed. Walk, exercise of some sort, 30 minutes a day. Dancing's fine. Whatever. Swimming's fine. Bowling's fine. Whatever you like to do, do it regularly. Now, remember I said that stress hormones are elevated. Well, a lot of symptoms come from those high stress hormones, and we can deal with them better if we've learned skills like mindfulness or meditation or relaxation, yoga breathing. There's many, many strategies. But when you feel yourself just getting all wired up, being able to calm yourself down to take a longer perspective is super important. And finally, remember I said the dropping levels of estrogen trigger bone loss? The most rapid bone loss that we ever experience occurs when we're still cycling in those late perimenopause or late transition period. So make sure you're getting enough calcium, make sure you're getting enough vitamin D. Pay attention to whole foods and vegetables and fruit. And there's ABCs of midlife osteoporosis prevention on the SEMCOR website. So now what about those crazy hormones where estrogen is way out of kilter? Well, first of all, the perspective we should have about these two hormones is that they are partners. It's a system. It never is estrogen alone. It's always part of a system, ideally. And one of the reasons it's important is because estrogen is an essential, it's a grand, powerful hormone, but it's a proliferating or growth stimulating hormone. And as long as it's around, it's making cells grow, which increases the risk for errors, genetic errors and cancers in particular. It turns out that wherever estrogen works, progesterone also works, and its job is to make that same tissue more mature, more differentiated, and to block that overproliferation of estrogen. So we need both of these hormones for pregnancy, and it turns out we need them for bones, we need them for breast health, we need them for all of our health throughout our life cycle. In other words, what happens in our premenopausal and perimenopausal years influences our health as we become older. So that's the perspective. So now I want to talk to you about something that's not physiological in the sense that progesterone is never alone. It's always preceded by estrogen in physiology, but progesterone as a therapy. We already said it's lower. We already said it counterbalances things estrogen does in the tissues. So I want to show you some evidence of that. And let's start with night sweats and hot flushes. So night sweats are just the same thing as hot flushes. They just happen during sleep. And if you're doing the shift work and you get a hot flush in the daytime when is your sleeping time, that's a night sweat. Okay. So we'll call them vasomotor symptoms because writing it out on a slide and VMS is hard. Okay. So there are many choices that women have today for treating night sweats and hot flushes. The current guidelines would say to take menopausal type estrogen progestin or progesterone therapy. And this is recommended for all symptomatic, or in fact, some say all women under 60, which is wrong. So menopausal hormone therapy is something that's being pushed right now. There are a few guidelines that still say take the birth control pill. It's got lots of estrogen. You're supposedly estrogen deficient. It's going to help you. The evidence is that it does not. There's a randomized Canadian trial from the late 70s showing it does not improve hot flushes. And remember, even the lowest dose pills today are 4 times a premenopausal physiology. So they're going to be even, it's adding even more estrogen to the environment that's already got erratic, but enough estrogen. The progestin releasing IUD that we talked about a minute ago, it's useful not for hot flushes. It's not been shown to be effective for that, but for heavy flow. And daily oral micronized progesterone or the natural progesterone. And this is something I finally got published in June of this year. But we did a study, and I want to spend some time sharing that study with you. So in 2010, we applied. In 2011, we reapplied and got the government CIHR funded funding for this trial, although they took away a third of it. So it was financially difficult to do. We enrolled 189 women from across the country. We had to make it a remote trial because Vancouver area women were just too busy to participate. It's tough. The women were ages 35 to 57. Their mean age was 50. Their body mass index was just above the ideal at 26.8. 66% had had one skipped cycle. So they were in late menopause transition on average. 57% were university graduates, which is something you often find in trial data. So our primary outcome, so half of the women were randomized to progesterone and half to placebo. The primary outcome was what's called a VMS score. It's a way of putting night sweats and hot flushes together into a single entity. In the third month compared to the month before they began therapy when they were on nothing. So each person compared to their own control. I'll show you why that wasn't significant in a minute. But we asked also, and thank goodness we did, secondary outcomes. And by the way, you have to spell out everything you're going to do in a study at the beginning, or you'll be accused of data dredging or whatever. So we asked a question about what women perceived had changed over the time, the 3 months they were in the trial, when they were taking either progesterone or placebo and didn't know which they were on. So we asked about vasomotor symptoms, about flow, and about sleep quality. We also asked, because one of the Data Safety Monitoring Board members insisted we do, a questionnaire for depression. They didn't want us to enroll depressed women who might be having more flushes because they were depressed. And we decided to measure it at the beginning and at the end, so we could see the change over time on whatever therapy they were taking. Finally, we asked a question, a line, 10-centimeter line, draw on the line, how much perimenopause interferes with your usual life. So here would be really high and here would be little. So we ask these extra questions. But first of all, this looks a bit like that estrogen diagram I showed you before. Good. So here the blue is progesterone at baseline and the black are the placebo, or well, nobody was on anything, but the ones who were randomized to placebo. So you can see how variable they were. Well, they continued being variable, although progesterone was consistently lower, the average hot flush, but this variability had never been documented before. So we really needed 250 or 300 women in order to show a statistical difference on our primary outcome. And it was because our primary outcome was not significant, although we couldn't exclude a benefit because a decrease of 3 was a meaningful, important difference for women. And the variability, the confidence interval included 3, but journals rejected it. So we had about 14 rejections over the last 5 years, largely because this was not a significant outcome. That's not scientific, by the way. If in the first ever trial, whatever data you get is going to help the next trial. Anyway, here's the important news. We did not show a change, a statistically significant improvement in hot flushes. It was close, but we did show a significant benefit in night sweats. And also, interestingly, the daytime hot flushes women perceived were less hot, less intense. which is interesting. Women also didn't perceive that there was any change in their flow and the heaviness of their flow. You see the mean line is here, right on no change for both the progesterone and the placebo, although a few more women stopped their periods if they were on progesterone than stopped them if they were on placebo. So it's largely not going to change a woman's menstrual cycle. But here's the great thing. Sleep highly significantly improved. And improvement in sleep often improves almost every other aspect of perimenopause. So this was 300 milligrams at bedtime. That's 3 little round balls. Unfortunately, they are terribly expensive now. It's almost $10, even with the generic. And that's largely because the company that has the distribution rights has just raised and raised and raised the price over the last 10 years or so. Oops, sorry. So repeating, progesterone improved night sweats. It improved sleep quality. And there's also evidence from before that it improves the sleep in menopausal women. There's many trials. There's even a trial in men showing it improves sleep. Progesterone decreased the interference women perceived that perimenopause had in their daily life. No, it's doing something more than just working on sleep and night sweats. And it did not increase depression or cause it. Again, very important news because progesterone tends to be blamed for depression, even though there's almost no evidence for that. Now, what about the other tricky one? And that's heavy flow. I'm not going to go through all of this. Some of you know it very well. But the important thing to take away is that ibuprofen, the normal, NSAID, that you can get with many, many brand names, 200 or maybe 400 milligrams with each meal on every heavy flow day, decreases flow by 20 to 40 or 50%, which means that if you're in perimenopause, carry some ibuprofen. It might allow you to continue doing what you want to do without having to go to emergency. Tranexamic acid, endometrial ablation, we've talked about before. The progestin-releasing IUD is effective for most women's heavy flow and perimenopause. But I also think daily progesterone, as we did in the study for women who are having heavy flow, decreases the volume of flow, takes away the heavy flow, and is an effective therapy. I haven't been able to get the funding to prove that yet. Now, what if you have regular cycles? You could take progesterone only for 14 days toward the end of the cycle. You could extend it if you needed to into the cycle because night sweats tend to be cyclic. So a perimenopausal woman needs to ask for what she needs, but before she can ask, she must have accurate information. She needs to be able to self-monitor and integrate what she's learning about herself. She needs help at work so that she doesn't have to lose her job or take long-term disability. And she needs healthcare providers who recognize what she's going through. So that's why we have the Center for Menstrual Cycle and Ovulation Research website. Just look it up and look there there's a whole section under perimenopause. There's a section for adolescence, premenopause, perimenopause, and menopause. There's also a free diary, and keeping track of the diary allows you to integrate the physical stuff and the mood symptoms. I found, for example, I got blue whenever my breasts were most sore. For me, and that was important to be able to figure stuff out like that. I've written a book, and in fact, the healthcare team has a copy that they're going to give as a raffle or some kind of a prize, but it's also available through the internet or through SEMCOR website. all of the royalties go to support the research that the Center for Menstrual Cycle and Ovulation does. And it's a story, it's fiction. There's a made-up doctor and 8 made-up women with different experiences. So it's a useful way to see how the diary can help, how a doctor can interact with a person who's having trouble. So the good news is we all graduate. And the important thing is that women who have a difficult perimenopause often feel so much better when they hit menopause. It certainly was true for me. Okay, so we've talked a lot about stuff, about how the society tends to equate perimenopause and menopause. We've talked about night sweats and heavy flow and estrogen, especially the role of dropping estrogen in the process, especially about very early perimenopause when the hormones have changed, the experiences have changed, but periods are still regular. And I hope that you will gather accurate information and also some kind of self-monitoring if you're having symptoms, because you can learn so much and you can take it with you to a healthcare provider. It actually helps very much for you to communicate what you're experiencing. And finally, if you need something for symptoms, if you're not coping, progesterone is now proven not only safe and physiological, but also effective. So I'd like to end with this. Ursula Le Guin was a writer that I valued very much. She's now passed away, but she said, a perimenopausal woman has to change her life. The woman who's willing to make that change must become pregnant with herself at last.
Thank you so much for this very informative presentation. I hope we all learned something.